Thank you, Dr. Rizwana, and thank you again for this opportunity. This is a talk I asked for. I mean, I think I was allocated a different topic, and I said that we should talk about this more importantly than, I don't remember what was asked of me. So I think it's very important to understand some basic things which I thought I'll talk about today. Uh, why is it important to ensure accuracy in hemodynamic measurements? I'm going to just show you 5 pictures. These are pioneers. I consider them pioneers. Dr. Locke is the person who trained me. I trained under Dr. Locke, who's the pioneer of catheter interventions. In some ways, the father of catheter interventions. Everything he did for the first time. Dr. Shakil Qureshi, you all know very well. Again, he's a tremendous pioneer and an inventor. Dr. Srivastav is my teacher at All India Institute, and she trained me in pediatric cardiology and interventions, and she did the first interventions in India. She was the one who did the first balloon mitral valvotomy, first pulmonary balloon valvotomy, and along with her, we did the first set of ASD devices. Dr. George Joseph is from CMC Vellore, one of the greatest structural interventionists who doesn't travel very much, but he is remarkably skilled. And then Dr. Philippe Bonhoeffer. What's common about all of these? Why did I show this photograph? Why I show them is because the common thread, of course, they have very solid foundations. These are people with extremely solid foundations. They can keep innovating. Dr. Adhikari showed so many techniques of innovations. Now that really, it's very important to have basics. Then you can do all these innovations. So the foundations are anatomic. So you should know your anatomy very well, emphasized. This is not given enough importance, and it's very important. And when you get into trouble, you'll realize why it's important. Then you should know your hardware very well, deeply. You should understand every item that exists in your cath lab. And finally, you should have an understanding of natural history to know who should be intervened upon. So with these foundations only you become a good interventionist, and the photographs I showed you were of people who had these foundations very well understood in them. So hemodynamic foundations is what we are going to talk about. It is a critical requirement. Again, underemphasized. You must know your physiology. You must correctly record your pressures and hemodynamic data. And then you should interpret them correctly and correlate them clinically. Only when you get all these 4 elements right, you can do interventions successfully and properly. Many interventions would happen without, any problems, like an ASD device would happen without much difficulty, but you can get into trouble in an occasional patient whose, let's say, EDP goes up and they get pulmonary edema post-procedure, and you haven't really paid attention to those details. And that can happen occasionally. And when that happens, you really have to do. The problem in today's times is that there are very few diagnostic catheterization. I grew up with diagnostic catheterization because I was in an era where echocardiography was not available, not very good. So we were doing a lot of angiograms for diagnostic purposes. So I understood that, and that gave me a lot of foundations, but today's generation doesn't have that opportunity. Problem is, we are also part of a system that delivers fragmented care. We try to say we are competing with the surgeons. We are doing this better than this. That's not how it should be. We are not competing. We have to come together to do the best for the patient. So we should avoid that fragmentation. And then everybody wants to do only interventions. That's also a problem. Nobody is giving importance to any other aspect. It's just the doing that gets all the glamour and the attention. It's good, but you have to understand that doers are not necessarily better than thinkers. You need to be both. You need to think and then do. If you just do without thinking, you'll do a lot of damage every now and then. So it's very important to have this whole concept that you really need to think about what you're doing and the effects of what you're doing. So interventions are often, we get a lot of kick out of doing. So we get a desire of doing something and we take precedence. This gives us an illusion that we have made things better for the patient. But we really have to be sure about that. I have been not been a very good, strong advocate of closing small VSDs in the cath lab because I think it's often not necessary. And then there are many situations where operability is borderline, but the tendency is to close the defect. No, that's again something that we have to consciously resist. There are many examples like borderline coarctation, 5-6 gradient. You attend these the big meetings in Frankfurt and other places. 5-6 gradient. They're putting stents in a 7-year-old child. No, that's clearly wrong. That's unacceptable. So it's important that we have to always ask ourselves, what is it that the patient is going to benefit from? Or really small ASDs. I've seen them being closed, 5 mm, 6 mm defects in a 5-year-old, which eventually may even close. Or a silent PDA. No, these are things that doesn't merit closure, in my opinion. So we have to think very hard, because sometimes you can do harm. So to be for good results and maximum patient benefit, firstly, do a very careful assessment. Don't disconnect yourself from the clinical situation. You must know if it is clinically appropriate. X-ray you should have seen. It should fit with your clinical evaluation. You should do a thorough non-invasive assessment. Of course, that is done to determine what size of the device, but that should also be to determine whether actually the patient needs it or not. It definitely helps plan the procedure. Very important to obtain hemodynamic data and make sure it fits with the clinical assessment. I'll give you an example. 6-year-old child came to us for an ASD device closure. And we have made it a routine to measure PA pressures in the cath lab. Always. Every ASD device prior to the procedure will do QPQS and measure PA pressures and ensure that there is no problems. Every now and then you land into trouble. So we had a 6-year-old with a PA mean of 45. That was missed by everybody. And I discovered this in the cath lab. We did not close the ASD. This patient is on our follow-up. I went back and listened to her, and I had missed the really loud second heart sound. So the thing that is very important is to pay attention to every small detail. Now this child continues to be on our follow-up, and if we had closed that ASD, she would have probably not been on our follow-up and died by now. So therefore, it's very important to get all the hemodynamic data correctly, accurately, and always do it before and after, whenever possible, after intervention, and have a careful, objective follow-up of our patients to make sure that what we have done has helped the patient. So let's start with accuracy of hemodynamics, and that's our topic today. So firstly, this is something that many people don't do in the cath lab, and it's dangerous. If you don't do it, you can get into trouble, which is to ensure the correct transducer level prior to every case in the cath lab. What is the level at which your transducer is present vis-a-vis the patient's central, what we call it as the phlebostatic axis, or the midpoint of the atrium. So what should you do in the cath lab to make sure that this is done? I'll show you, and this is something I discovered that they were missing it in my lab too, then I insisted that it is done. So the fact is that your transducer has to be in the mid-chest level, and you have to take some time to ensure it prior to every case. So this way you can do it by placing this device, which is a long rod with a spirit level, and this video has been shared to me by Dr. Babar Hassan, a good friend of mine from Karachi. And you can see that the transducer is placed in this particular example. You can see the rod that has the spirit level. You can see there is another spirit level that tests the vertical orientation, and this one ensures that bubble is in the center, so this is perfectly horizontal, and the patient has it at the mid-chest level, and you have zeroed the pressure tracings after opening it up. So therefore, you're ready to go. Now, this is a very simple step. If you ignore it, you'll pay a price in selected patients. So where do you have the real problem? When you measure low pressures, like atrial pressures, capillary wedge pressures, end diastolic pressures, if your transducer is placed 10 centimeters higher, your correct level of 12 millimeters will be reported as 4. If it is placed lower, the level will be reported as 20. Now, it's surprising how many people don't do this. The vast majority don't know about this. So when we ask our students, they have no clue. Now, that's the dangerous part, because then you don't have accurate data. And accurate data matters a lot, not just in interventions, but prior to Fontan. If you send a patient to the surgeon for a Fontan operation and you don't get this data right, and the patient does badly after surgery. you start blaming everybody, the surgeon, the intensive care, everybody. You don't realize you have not selected the right patient. So paying attention to this is super important. So you keep the transducer, as you see that this transducer is exposed to atmospheric pressure, and you can get that sorted out right in the beginning. You calibrate the transducer. Of course, you have to do that with a mercury manometer or ask the company to do it. Level it correctly, zero it, aspirate and flush all your catheters, check all your connections and bubbles. Make sure your catheter position is not trapped inside some atrial appendage or the apex of the ventricle. Ensure that the catheter is optimally damped, and I'll talk to you about it. And you have to report end expiratory pressures. Whenever there is respiratory variation, report the end expiratory pressures. That's the correct pressure. So damping is very important. If you have a poorly damped system, under-damped system, you will have these flicks and you will report higher than normal pressures. If you have an over-damped system, you will report lower pressures. The mean pressure will not change, but the systolic and diastolic will be altered. So you have to have it optimally damped. And damping is essentially dissipation of energy. It's determined by the viscosity of fluid, fluid density, and the catheter radius. So if you have a long catheter and a narrow catheter with air bubbles, you have a very inaccurate, highly over-damped system. If you have too much blood, thick blood, high hematocrit in the system, you will have an over-damped. If you have leaks, you will have a lot of loss of fidelity. So whatever the pressure is inside the body will not be reflected in the transducer. If you have a very fast heart rate, you cannot record end diastolic pressures. So these are all things that are very important. So if you have a poor, lots of bubbles in your system, you will have these kind of artifacts. But after flushing the transducer, you get a more smoother trace. Other artifacts, very important to remember, there's something called as end hole artifact. So when your catheter is pointing towards the direction of flow, like you have a radial line, you will have the direction of flow into your catheter that produces extra pressure because of kinetic energy, and that's essentially what is called end pressure artifact, end hole artifact. When you have a catheter whip artifact, if you see consistent whips in the trace, then you know that this patient should not report an excessively low diastolic pressure. You have to pay attention to that. Then, whenever you do a pullback from LV to aorta, don't take the femoral artery to report your gradient. If you have aortic stenosis, report the ascending aorta because you have amplification. Even in aortic stenosis, you will have amplification because of reflected waves. So you really have to pay attention to these small details. Flow calculations are very important because here you make much more errors. And we apply the Fick's principle where you assume oxygen consumption and then you calculate the content of inflow minus outflow. Now that's the Fick's principle, very simple principle, but lots of errors can happen. First error is in measuring oxygen content. So you have to make sure that you get this correctly measured where you use hemoglobin into 1.36 into saturation of oxygen, and you have to add dissolved oxygen. Now this is something that people don't do. They give 100% oxygen in the cath lab, but they do not add dissolved oxygen and you get all wrong values. So you have to add dissolved oxygen, which is 0.03 into of oxygen that should be added multiplied by PO2, and that has to be added to the oxygen content. So this is how you do it. In systemic blood flow, you have oxygen consumption divided by the difference in oxygen versus mixed venous saturation, and in pulmonary blood flow, you have pulmonary venous minus pulmonary arterial saturation. So essentially, this is how you do it, of the oxygen content. And for QPQS, you don't really need, you can just calculate the ratios. You don't need oxygen consumption. For PVR, you take the transpulmonary gradient, which is pulmonary artery mean minus pulmonary venous mean. And for pulmonary blood flow, you have the calculation, which is based on oxygen content in the pulmonary vein minus pulmonary artery. Oops. I'm running a little short. I won't take very long now. In shunt ratios, only oxygen saturations are needed. Lots of errors in oxygen saturation, streaming, partial wedging, and getting samples in different physiologic state, very, very important. Diluted samples, air bubble in syringe, machine calibration, extrapolating from an old ABG machine. Nowadays, you don't have that problem, and failure to account for dissolved oxygen. Oxygen saturation errors, I told you about all these points, and taking non-representative samples. That's also a problem. When you take right atrial sample, that's not mixed venous saturation. That is, you have to use SVC in children or the FLAM formula, which is 3 SVC plus 1 IVC by 4 in adults. You have to factor in anesthesia also. So this is a summary of all what I have told you. Okay? So the parting thoughts is that you should really have accurate hemodynamic data. That's fundamental for every interventional cardiologist. And you have to pay attention to these details, which is accuracy in pressures, flow and resisted estimation, and you have to correlate with the clinical picture. Thank you.
Thank you, sir.